Today we will continue our examination of research on doctor-patient communication by examining the sharing of decision-making between doctors and patients in the medical encounter. I have selected this topic as an example of the kinds of questions that people in this area of scholarship examine. Quite a few definitions of shared decision-making have been offered by researchers. This definition by O'Connor and colleagues is a fairly standard one. Shared decision-making is defined here as the process of interacting with patients who wish to be involved in arriving at an informed, values-based choice among two or more medically reasonable alternatives. We see here that shared decision-making is not an event, but rather it is a process of interaction that unfolds over time. The decision we are talking about usually pertains to a treatment plan for a medical issue. Shared decision-making is found in situations in which the patient has at least two medically reasonable treatment options and thus needs to make a choice. The push toward more shared decision-making is part of a larger movement in medicine, the patient-centered care movement. Patient-centered care can be defined in terms of its polar opposite, doctor-centered care. It would be useful to compare and contrast these two approaches to medicine with regard to four communication differences. One of the first things a physician needs to do in a medical appointment is develop the agenda for the visit. A patient-centered doctor first talks to the patient, asks about his or her concerns, worries, and such, and uses that information to build an agenda for the visit. The agenda reflects the patient's perspective on their situation. In contrast, a doctor-centered physician decides on the agenda based primarily on biomedical considerations. These two approaches also differ with regard to the solicitation of information from the patient. A patient-centered physician will try to obtain a good deal of information from the patient. The patient will be asked questions and invited to ask the doctor questions. The patient will be given an opportunity to tell their story without interruption. The patient-centered doctor, in fact, knows that much can be learned from listening to the patient's health narrative. In contrast, a doctor-centered patient assumes that if patients have something important to say, they will share that information with the doctor. No active solicitation or invitation to provide information is needed. The patient-centered doctor will also be concerned about the emotional state of the patient's worries, concerns, anxieties, and so forth. These emotions are important. The doctor-centered physician, on the other hand, will be more inclined to sidestep or ignore such issues. What's important is the patient's objective physical state. Now we get to today's topic. The patient-centered doctor will approach decisions about treatment as a shared endeavor. This doctor will actively encourage the patient to be involved in formulating a treatment plan by exploring various options available. The doctor-centered physician, on the other hand, will decide on the best course of action. The doctor is the expert, after all. The decision will be explained to the patient, probably with a justification. We will now return to shared decision-making. As I noted at the outset, a number of definitions have been offered. McCall and Clayman recently examined dozens of research reports on shared decision-making to identify the essential features of shared decision-making, the features that must be present in true shared decision-making. The essential features are a dialogue between the doctor and patient to define and explain the problem, physician review of options that are available to the patient, discussion of the pros and cons of each option, explorations of patient's values and preferences, discussion of the patient's abilities and self-efficacy, doctor shared knowledge and recommendations, doctor checking a patient understanding and clarification if needed, the making of an explicit treatment decision or an explicit decision to defer until later the treatment decision, and finally, arrangement of a follow-up visit to review the decision and its outcomes. McCall and Clayman write at length about how the qualities of interaction are fundamentally changed when doctors practice shared decision-making. Most notably, patient participation will be high. Patients will be given information, asking questions, exploring different treatment options with the doctor, and so forth. The effect is that the doctor and patient will form a partnership characterized by mutual respect. The approach will be, we are in this together. As part of that partnership, there will be much exchange of information, with information going from doctor to patient, but also from patient to doctor. One effect of this is that the doctor will be providing much patient education. The doctor will see the physician role as that of teacher. When making decisions about next steps, the interaction will not be one in which the doctor tells the patient what to do. Rather, a decision will be made through deliberation, a discussion of pros and cons, for example. There may also be negotiation. The doctor might think the patient should have surgery, for example, but the patient may want to wait and see if things get better. The two may negotiate something along the lines of 1 month of watchful waiting, followed by a reconsideration of the surgery option if the patient doesn't get better. In other words, the doctor and patient will try to find a middle ground, a compromise, when there's disagreement about the best course of action. Every patient is different. As a result, the doctor will be flexible and work with the patient to make a decision that is individualized, that is, personalized to the patient's situation, values, and preferences. As you can see, shared decision-making can take time. So what is the payoff for all of this? What are the health outcomes? First, there are higher levels of adherence to treatment plans, especially among patients with chronic health conditions. This makes sense. Wouldn't you be more willing to follow a treatment plan that you helped to develop than one that was handed down to you by a paternalistic doctor? A second outcome appears to be greater reliance on preventative behaviors, including regular checkups, screenings for disease, and immunization. This also makes sense. Shared decision-making requires an informed patient. The patient education that the doctor provides may be partly responsible for the uptake of preventive behaviors. The third and fourth outcomes may flow directly from preventive actions and adherence to medical treatment plans. These are a lower probability of emergency room visits and lower rates of hospitalization. Shared decision-making is not found in all medical encounters, obviously. In fact, it may not even be practiced at a high level of skill in most encounters. The factors that make shared decision-making more likely fall into three categories: patient factors, physician factors, and relational factors. Let's explore each of these in turn. Shared decision-making is more likely to be found in visits in which the patient is skilled at finding information, evaluating information, and figuring out how to use information. People differ dramatically in their abilities to find, understand, and use health information. These health literacy differences are well studied. People who are good at health information seeking and evaluation of health information are more likely to want to share decision-making in their medical encounters. Some patients are inhibited, shy, introverted. Other patients have less inhibition in interpersonal encounters. An outgoing person is more likely to feel comfortable with shared decision-making than a reserved person. Some patients think of themselves as consumers of health information. Like any good shopper, they want to have a high level of control over what they buy into, figuratively speaking, when they see their doctor. Other patients have a more traditional view of their health care, preferring not to think of it in consumer terms. A consumer perspective facilitates shared decision-making. The United States and Western Europe are furthest along in the patient-centered care movement. A patient who came to America from a doctor knows best country and is not yet acculturated might not even consider the possibility of sharing decision-making with the doctor. Physicians do not all approach shared decision-making in the same way. One factor that appears to be important is the amount and quality of training a doctor has received in shared decision-making and patient-centered communication. Physicians who actively encourage information seeking will probably have more informed patients who will be better equipped to participate in the healthcare decisions that affect them. Finally, we know that some doctors are genuinely and sincerely supportive of the notion of patient choice and involvement. Other physicians just as genuinely and sincerely believe that they should be in charge because they are the experts. Relational factors refer to those factors that facilitate shared decision-making that are tied neither to the patient nor to the doctor, but rather to the relationship they have developed over repeated visits. Over time, a patient and doctor can generate a high level of mutual respect and trust. Mutual trust and respect facilitates shared decision-making by opening channels of communication. Second, over time, the physician can come to know the patient as an individual. This allows the doctor to tailor dialogue around the patient's values and preferences. A third physician-level facilitator that has been examined is shared identity between the doctor and the patient. A doctor and patient can have a sense of being a we, not a you and I, because they've come from the same culture, are the same race, perhaps are of the same age, and so forth. This sense of shared identity may help the patient to feel comfortable in the medical encounter and thus more willing to share information, express values, ask questions, and so forth. The things that make shared decision-making possible. Do all patients prefer shared decision-making? This is the topic of our next video.